Thank you very much. I must say that most of the time, isolated side branch disease needs medical therapy and nothing. But there are some situations where maybe angioplasty is necessary. I have no conflict to report. We published this left main lesion requiring two-stent strategy, and there was a higher occurrence of TLR for restenosis of the left circumflex coronary ostium. And these procedures were mainly done with HyBiz guidance. Despite this high restenosis with the hazard ratio of 2.5, there was no cardiac death at 2 years in patients with restenosis of the circumflex, and the minimal impact on symptoms. So basically, this side branch problem is a visual problem more than a clinical problem. This is a typical situation where we face. There is disease, of course, in the left main and in the LAD, but this LAD is FFR negative, and the disease is concentrated at the ostium of the circumflex. So the question is, should you stent? One stent strategy, two stents, because we know that how frequently after placing a stent on the circumflex, you may have carina shift, plaque shift, etc., etc. So this is not clear. But if you do a stenting of the circumflex, and if you are then forced to do two stents, which is something that we try to avoid, but it may happen, it's a must to have a large lumen on the circumflex. This is the original paper of Kang, 5 square millimeter. I don't believe 5 is sufficient. I think you need at least a 6 or 6.5 in order to be relatively safe against restenosis, but not so safe. So the bottom line is that we try to minimize the need of stenting of the side branch. And how do we make this decision? This is a typical example where if you look at this angiogram at the baseline, you will say that you need a stent on the circumflex. And nowadays, we rarely make this decision by looking at the angiogram at the baseline. There is no need to say at the beginning, do I need 2 stents or 1 stent, or even do I need a stent? This question does not need to be answered when you see the angiogram, and not even when you see IVUS or OC. This question needs to be answered after you have done pre-dilatation. So in this case, we dilated the circumflex with a 3O balloon, high pressure. We did a kissing balloon, which is something that is not suggested to be done, but we do it. And after kissing balloon, we do the angiogram, and you see that there is a good result on the circumflex, because frequently angioplasty works, believe it or not. So at this point, we continued, and we did the stenting left main to the LAD. Then we did dilatation of the struts towards the circumflex. You may argue that this is not necessary all the time, as we heard before. And then we did a kissing balloon, and we utilized a drug-coated balloon because the result was still adequate, and this is the final result. So the decision to treat the circumflex was taken after pre-dilatation and not at the baseline. And this is a message that I would like to transmit regarding side branch. The side branch decision is not taken at the baseline, but after the result following pre-dilatation. So 1 stent, left main LAD, and provisional with kissing balloon. This is a typical case, which is a real pain in the neck, isolated disease of the circumflex. You place a stent at the ostium, there is some protrusion, long-term result is very unpredictable. In this case, we did balloon dilatation, no stent, a final drug-coated balloon. This is a 1-year result. There is some late loss, but it's very minimal, and the lumen is maintained. So this is what I call a more modern way to approach a side branch disease. This is a more severe disease of the circumflex, a diffuse disease confined to the ostium, but extending to the body. This disease in the old time, we would say absolutely stenting. Now, absolutely, I don't know. We pre-dilated, we had a reasonable result, there is some dissection, but the lumen, residual lumen is fine. We did a drug-coated balloon. This is 1-year follow-up, which is well maintained with no compromise of the left main and the ostium. And to final, I would like to say that even if the circumflex or the side branch is severely stenotic, this may have no clinical impact. This is a lesion that all of us will be ready to treat and to stent. The FFR was 0.90 with adenosine peripherally given, high dose. We checked with SPECT and was negative, and despite this tight stenosis, there was no clinical need to do anything. So don't be always pushed by images, but we are still doctors and we don't make the decision based on pictures but on clinical situations. So to conclude, we should try to minimize the usage of stenting as the ostium of the circumflex, but I would like to add as the ostium of diagonals, OM, any side branch. And when stenting cannot be avoided, because sometimes it is necessary, imaging-guided optimization should be pursued because the side branch stenting is a malignant situation. Thank you for your attention.
Thank you very much, Dr. Colombo. I think this is extremely important points which you raised about how to treat a ostial circumflex disease, because sometimes it is de novo and at times it is because of a sequelae of a first stent from left main to LAD. So in both these situations, as you already mentioned, that avoiding a stent is a better technique. And what is your idea about using cutting balloons like Wolverine, or any other device, if it is very calcified, even a shock wave, and then assess whether we need to put a stent or just a drug-eluting balloon?
But we are very liberal about using a cutting balloon as the ostium of the circumflex, because we know that there is disease. It's always difficult to make a decision and say when to stop to being too aggressive, because we all know that unless we do directional atherectomy and we remove the plaque, if we push the plaque away from the circumflex, it will go towards the LAD and the left main. So this is not an easy decision, and it's a matter of art, you have to decide case by case. Depends how big is the circumflex, how large is the territory. And many patients do a normal life, even if they have a stenosis of the circumflex, or of the diagonal. So let's not be too concentrated about picture taking.
Dr. Colombo, can I ask a question? It's a very important topic and important discussion, because circumflex ostium is really a pain for all of us. So what I want to ask you, that is the philosophy, your philosophy of ballooning and using drug-eluting balloon will still hold true when the circumflex is a very dominant vessel?
No, doesn't matter if the circumflex is a dominant. I think it depends on the result you achieve after pre-dilatation. But we all know that if the circumflex is very big, if you place a short stent and you place it well, the results are going to be good. I'm not trying to go against stenting. I'm trying to say not to stent when it's not necessary.
Right.
Can we make use of can we have a drug-eluting balloon at the circumflex ostium instead of a stent?
Yes, but that's my hypothesis generating. I hope it will take another 2 years, but I think in 2 years I will provide some data. Dissect it.
Case that you showed, where the circumflex was very tortuous and very badly diseased, and you showed that after balloon dilatation there was a dissection, and it looked on angiographically that the dissection was quite extensive. Now, how do you decide that drug-coated balloon will be enough for this case, and I would not stent it? Because you will have to come out, you will have to take everything out, the wire out. And based on what do you decide?
New generation interventionists are not used to accept dissections. So every time you see a dissection means stenting. We don't suggest to do IVUS to evaluate a dissection because in clinical practice people don't do that. The way to evaluate a dissection is the residual angiographic lumen. If you have a dissection, but the residual angiographic lumen is large or sufficiently large, we accept the dissection. And I've been doing this approach for the last 2 years, and I did not have a single occlusion. So residual angiographic lumen, if large, dissection can be accepted. If the residual angiographic lumen is compressed or small, you need a stent.
Okay, and you do a 1:1 balloon dilatation? Do you do a 1:1 balloon dilatation?
Yeah, 1:1. And sometimes the last resort before placing a stent is to do another dilatation with a little bigger balloon. Believe it or not, sometimes a bigger balloon helps to make the dissection a little bit bigger and makes the residual lumen large. So converts a malignant dissection into a benign dissection. Don't be afraid because you always have a stent in the lab. So whatever happens, as long as you don't break the vessel, you can place a stent.
Thank you.
Biovascular scaffold about consideration to LM to LAD.
The BVS, after doing the treatment of the ostial circumflex, will you still consider a absorbable scaffold?
You know, the problem of absorbable scaffold, my emotional answer is yes, but we all know we can make a full day symposium about BVS. So I give you emotional answer is yes, but that's it.
Right now we do not have much data to support that, but certainly this technique of treating the ostial lesion well with whatever you want to do, you do shockwave, you do a cutting balloon, but the dominant strategy is a Wolverine in these situations and then get a stent-like result. And many times, if you have a FFR wire up front, there is a FFR wire down the vessel, and then you can check the FFR. If everything is okay, image looks good, you can do a DB and just stop.
But my main message is do not be too concentrated on ostial lesions. The best way to avoid ostial lesion problem is not to do angiography.